Good afternoon, good evening. Welcome, everybody. Welcome to the Stop LAPD Spying Coalition third Tuesday of the month general meeting. My name is Hamid Khan. I go by he, him with Stop LAPD Spying Coalition. And we are really happy and excited to have our incredible public health crew with us today. Who will be walking us through a bunch of things, especially that, just talking about public health and the implications around social justice movements, while public health being a key tool or a key process that has provided us some safety nets and things like that, but how public health, also the tools and the same strategies really keep on continuing white supremacy and white supremacist systems, both locally and globally. So before we get started, it'll be great that, when we are in person, then, we would kind of just do a different icebreaker or get to know you. But if folks won't mind, if they wouldn't just go and chat and to everyone, and then your name and pronouns, and if you're with an organization or any particular interest brings you to this conversation, please feel free. So at least we'll virtually get to know each other. We have a pretty busy agenda, and I want to welcome Jamie, Bita, Lisa, Breann, and Mienah, folks who've been really our guides over the last, at least, if not more, over the last couple of years of how we've been navigating the surveillance state, the impact of COVID, and how information sharing environment moves. So with that, I guess I am going to hand it over to Jamie and Bita, I guess. So take it from there, Jamie. Thank you.
Okay. Hey, everybody. Good to be here with everybody. It's a Tuesday night and the sun is going to be up for a long time still. This is the longest day of the year, right? Am I correct about that? So that's pretty exciting. So my name's Jamie. I am a registered nurse. I've worked in the community of East LA, Boyle Heights for about 13 years. Have been on the front lines of COVID over the last 2 years and been a frontline nurse for that long too. So I just wanted to kind of introduce a little bit of what we're going to do on the first half, and then Bita will talk a little bit about the second half, and then we'll get started. Just to kind of, there's going to be a lot of information exchange today, so I wanted to kind of continue to just help navigate through information. I'll let Lisa introduce herself when we start, but Lisa and I will be basically walking people through kind of where are we at in the current moment. I know that Hamid, and in our flyer we mention about public health and its relationship to policing, but we definitely don't want to kind of have an all or nothing or a black and white kind of perspective of public health. And we want to be able to share the tools that people can use that can help them stay safe, tools that people can use to help you navigate what is really going on in your community. Because I think one of the biggest things that we need to realize is that there's a lot of information around us, and where are sources that are trying their best to give us the most direct and beneficial information as far as things go for COVID. So we'll be taking you through one of the county public health updates. They have a weekly update every Thursday. We'll be taking you through some websites, and then we're also going to have a community discussion on what does community facing solutions and self-defense and protection mean during these times, during COVID. Especially trying to center communities that are often left out of the conversation, which are communities that are disabled, communities that are immunocompromised. And what does it mean to us as people who are saying that we are social justice, fighters, social justice warriors? What does it mean? What kind of responsibility do we have as organizers, as community members, to our own communities and to people who are on the front lines trying to care for us? So that'll kind of be the first part. And then I'm going to pass it to Bita to talk about what's going to be happening in the second half.
Hi, everyone. Can you all hear me? Are we good? Okay. It's good to be back with you all. I know that we all got connected really early on in the pandemic to kind of bring together the different approaches to better understanding what public health is, to specifically thinking about public health surveillance, and then to more broadly to be thinking about in pandemic response, pandemic disaster preparedness, what are the implications for this in terms of how society is going to be rearranged, what policies are going to be put into place, what things are now going to become normalized that either like entrench us more into the things that we know are not the solutions, whether that's technology, right, or enhanced surveillance, or are they going to really give us an opportunity to be able to move forward in a different way? As we know, all people, animals, all life forms on the planet, including the planet itself, right, needs another way forward. So, you know, we've been doing this work and thinking about these kind of bigger themes and just bringing them down to concepts such as like thinking through public health and its relationship to security, securitization, public health and its relationship to surveillance. And so what we hope to be able to do when we get to our section is to give some of this historical context so that we can see when we're talking about, for example, public health surveillance, what do we mean historically when we say that public health surveillance has been weaponized against the communities, right? And so we'll go through some of those examples. And then we'll also talk about contemporary examples during COVID-19, where we see that public health surveillance was used and weaponized against communities, getting back to what the coalition always talks about as this continuum, right? Like these are not moments in time, you know? This is all part of a continuation of history. And so we'll do that historical and then that contemporary. And then we're gonna move into, Mienah and Breann are gonna move into giving us a very specific example of a contemporary type of public health surveillance that was weaponized against people in the example of Title 42. And Title 42 is a very important example because it is a policy that went into effect 7 days after the Trump administration declared this a pandemic. So it was one of the first public health laws to put into practice, one of the first public health surveillance responses to the pandemic. And as Mienah and Breann will take us through, it's been a very complicated history, both revealing where public health stands on this, and then also the larger intentions of securitizing the state and expanding surveillance, in particular when it comes to, through the lens of understanding what's going on with migrants at the border. And so, and then we'll end with giving some more references and historical context as to why, when we're thinking about like domestic examples of public health and public health surveillance, we have to be thinking about also the international, because it's, and as Stop LAPD Spying Coalition does so well, right? Like the domestic and the international, there's no real like separation between the two. And languages and actors in one, or is language and actors, right, in another, that not only share resources but also shared histories. And so we'll end with a conversation about that. We hope to give a lot of references in our presentation, and then we're going to put them in the chat. But ultimately, the important thing is, as Jamie said, for us to do a conversation, like to have a conversation and to think about what our next steps are in terms of coming together and building out the work of the public health group.
Well, that's a lot. Like I said, we're going to have a lot of information today, so so hang tight with us and always slow us down if we need to be slowed down. And we're about to dive into numbers right now. So I'm just going to pull us back a little bit and kind of talk a little bit about how do people figure out what's going on with COVID, right? How do we know if we're surging? How do we know if we're not surging? How do we know when to wear a mask? How do we know not when to wear a mask? Where do we get that information from? And who and why are the people we're getting the information from giving us particular types of information? So I want to just kind of do a quick just check to see, do most people check the daily COVID rate count through the LA County dashboard? Like if you can just put your little smiley face, your thumbs, does anybody use that LA County dashboard? Okay, a couple. Let me see over here.
Can we turn our camera off if we don't?
No, some don't. Okay. So how about Instagram? Does anybody subscribe, or how do you do it? Like on Instagram, LA County Public Health. Okay, so a lot of people like that. Okay, so so I'm just going to share my screen right now, and this is probably what most people see. So when everyone can see this, right? Yeah, I can't see everybody. Can everybody see this? Someone give me a yes.
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 Okay, cool. Thank you.
Jamie, we can't hear you. Oh, sorry,
yeah?
sorry. You're fine. You're fine. My bad.
No,
my
no,
bad.
you're fine,
Oh,
Jamie. Mhm.
okay. All right, cool. Thank you, everyone. So this is from Instagram. LA, you can see right up here, LA Public Health. And this is a daily update, right? They update Monday through Friday. Now, this gives you the daily case rates, the new deaths, how many deaths we've had. And this was from yesterday, so there was 2 deaths yesterday. And they don't have the numbers of currently hospitalized. And then they have this number down here of today's positivity rate, right? So what do we do with all these numbers? And this is kind of what I wanted to talk about. One of the biggest numbers I think that's really important is the test positivity rate. And right now we can see we're at 9.8, right? Well, before I kind of go into what the significance of that is, this test positivity rate basically talks about like how much of COVID is in the air. And or how many people who are testing positive for COVID, right? And so what is the community spread out there? How many people are actually testing positive? We used to, back in the early days of COVID, we used to base everything off of our positivity rate. And there was a little chart that we actually wanted to show earlier on that told us what to do with this number. So down here on the left, you see the California guidelines of 2021. Test positivity was what we based wearing a mask on or not wearing a mask on. And so if you remember from the slide before, it said 9.6. And so if you went to this little chart, anything more than 8 was widespread, right? If you go to the right, these are the CDC guidelines from 2021. And you can see that anything greater than 10 is high transmission. Anything from 8 to 9.9, you're at substantial transmission. So back in the day, and as I had put in this slide, old indicators and thresholds before the vaccines happened, being at more than 8% or more than 10% was considered widespread, right? So so I make a point of saying that because things changed, right? So everything used to be on positivity, and then that was when they would start to kind of institute indoor masking. At various times we had shutdowns, but it was all really around that test positivity rate. And I could go through all the amount of people that get tested, what they do with those numbers, but really it's like focusing on test positivity. That's the big number that I wanted us to focus on. And so as we can see, when you look at California guidelines and you were looking at the CDC guidelines, that anything over 8 was pretty much, it's out there. It's spreading high and wide, and we should really be doing something about it. But a few months ago, and correct me if I'm wrong, I think 3 or 4 months ago, the CDC decided that because we were vaccinated and because enough people had a prior infection with COVID, that we could actually change the metrics. And what they decided to do was to change the metrics to looking at the number of people who are admitted into the hospital with COVID and the amount of beds that are occupied with COVID patients. Now, and we're going to watch a little video from the LA County Public Health YouTube page that talks a little bit about this. But I wanted to kind of slow down and say that test positivity kind of went out the door. And yes, they look at how many people per 100,000 people have COVID, right? That is a marker. But test positivity kind of just left. They're like, we're going to base everything on hospital beds, right? And I'm a frontline nurse. So when you think about hospital beds, one thing that I want folks to think about is that back in the day, or if you know anybody who got sick, when did they actually enter into the hospital, right? So they got sick day one, started having symptoms. It isn't about till day 7, day 8, day 9, day 10 that they hit the hospital, right? Because now they're sick, now they're not getting better, now they can't breathe, now they're having complications. So they hit the hospital, they get admitted, they're in a bed. So when you think about this transition that CDC did, instead of going at how many people are testing positive, which is on kind of the front end, they decided to switch to the back end and to look at only hospital admissions and hospital bed occupancy. So where we're at right now, our metric is only alerting us to put a mask on, to change our behavior kind of at the back end. So now things are surging and the hospitals are filling up. And now we're finally getting to what the term was. And I don't know if folks remember, but the term used to be bend the curve, flatten the curve, do something, spread out. We want to get the numbers down before things accelerate and start to exponentially grow. And we're actually surging. So now we're not doing that anymore. We're kind of test positivities out the window. We don't really kind of base our behaviors on test positivity anymore. Now we're going to base our behaviors on whether or not hospital beds are occupied or a certain amount of people are being admitted into the bed. So Bita, if you can, I wanted to show that first clip. And before we push play, what's going on is that every Thursday at 2 p.m. on LA Public Health, and we're going to drop the link, YouTube page, they update the community on what is going on. But I wanted to make a point because what she's going to talk about in these metrics that are going to either trigger indoor masking or not are really new metrics. The old metrics went out the window. And I want us to think about that because as Bita in the second half unpacks public health structures and systems, why would the CDC want us hanging out more, spreading the virus more, waiting till the hospital beds to fill up? What is their motivation? And, I automatically think, well, that's white supremacy for you. Keep you out there shopping and hanging out and spending your money, right? Until the hospital beds fill up, then we finally do something. So it's really important that we understand that before we had the vaccines, there was test positivity. And then after, now it's let's wait till the hospital beds fill up, then we'll actually do something.
We do continue to track the impact of the pandemic in LA County using the CDC COVID-19 community levels framework, which is a measure of the strain on our healthcare system. Currently, we do remain at medium community level. The first hospital metric, that's the 7-day total of new hospital admissions per 100,000 people, increased to 7.3 admissions per 100,000 people. This is twice as high as it was 1 month ago, but again, relatively stable over the past few days. The second hospital metric, the 7-day average for the portion of staffed inpatient beds occupied by COVID-19 patients, that's up slightly as well. It's at 3.5%. Per CDC, 19 of California's 58 counties have moved into a high community level. All of those counties, I believe, are in Northern California. Next slide.
Okay, if you can pause. So one little fact too, the LA Times reported of those 19 counties that are at high community levels, only one of them has instituted indoor mask mandates. So we see this battle that's happening within communities as to whether or not we're actually going to do something to flatten the curve or we're going to continue to let spread happen. So again, these are the new CDC COVID-19 community levels. And again, they're based on hospital capacity. So you have hospital admissions. So right now there's 7.3 people. I know that 0.3 is always weird. Like, how is there 0.3 of a person that are being admitted into the hospital over 7 days, and 3.5% is the average of, no, sorry, I'm just seeing Akil, I'm seeing your your question right now, and no, it doesn't. It doesn't include, Akil's asking if the test positivity rate includes the antigen test, and it doesn't. So it's an inaccurate count, and it's actually probably higher. So just going back real quick to this 3.5%, this is the amount of hospital beds in LA County that are being occupied by COVID patients. And so, Bita, if you can just continue on, Barbara Ferrer.
With hospital admissions
yeah.
steadily increasing, we do face the prospect of moving from the medium community level to the high community level if we reach that CDC established threshold of 10 or more hospital admissions per 100,000 residents. We again updated our analysis on when the hospital admission rate might surpass 10 new admissions per 100,000. The blue solid line shows the rate between June 1st and June 14th. Those are the actual numbers. The green dashed line is the projected rate based on the experience of increase over the past 2 weeks. And the yellow dashed line shows the threshold rate of 10 hospital admissions per 100,000 residents per week. That will put us at the high community level. As you can see, the current estimate has us reaching that high community level threshold by the end of June. Should there be a change in the rate of increase among hospital admissions, the date could be earlier or the date could be later. Another possibility that would change our designated CDC community level is if our weekly case rate drops significantly over the next couple of weeks to under 200 new cases per 100,000 residents. This would change the hospital metric thresholds that are applied to determine our community level. Since our current weekly case rate is, I think, at about 343 new cases per 100,000 people, we'd need to see a pretty big decrease in our case rate for this to happen. I want to note that should we cross the CDC threshold for high community level, the county's position to align with the CDC framework that calls for universal masking indoors. We would implement required universal indoor masking after 2 consecutive weeks of being at the CDC designated high community level. And we would withdraw the safety measure requirement once we've returned to the CDC community level, medium community level designation for those 2 consecutive weeks. This would mean that while we're at the designated high community level, indoor masking would be required for everyone ages 2 and older in all indoor public settings. That includes businesses, offices, schools, retail stores, factories, and at event venues. Next slide.
Thank you, Bita.
The early alert signals remain.
So we can stop sharing now too, please. So one of the things, I'm going to pass it over to Lisa now, but I think one of the things that as a frontline healthcare provider, I can be quite honest right now that the hospital hasn't recuperated. And using the metric of the hospital as the determinant, as the trigger that gets pulled when, as the metric for pulling the trigger of asking people or requesting or demanding that people put on a mask is really unfortunate, because there are many days when after the first surge, the very heavy surge that we had in the end on the December 2020, many nurses left the field. And ever since that exodus, we have not recuperated. During the surge of the winter 2021 surge, not only did we not have enough staff, but then all our staff started to get sick. And so there wasn't enough nurses to take care of patients in the hospital because nurses were getting sick. And yes, we weren't surging with COVID patients in the hospital, but everyone was sick. So now, knowing that the CDC is determining whether or not we decide to indoor mask based on hospitalizations, for me as a healthcare provider is really insulting, because it's saying not until you feel the pressure are we going to tell anybody or recommend to anybody to actually change their behavior. And just so that folks know, 3%, 10% of hospital beds occupied by COVID means, especially working in East LA, especially working in South Central, means that, your elders are not having access to, to treatment. They're not being able to come in if they have, diabetic ulcers, if they have, hypertensive emergencies, if they have a cardiac arrest, if they have a stroke. And there's been many times before COVID that working in East LA, working in Boyle Heights, the hospital shut down itself because we ran out of beds just servicing the community before COVID. So so using the hospital beds as a metric really still continues to put stress on healthcare providers. So that's just one thing I wanted to end with, and I'm going to pass it over to Lisa.
Jamie, sorry for that interruption. Are you taking questions yet, or because there's a question in chat?
Oh, sure, I can take one right now.
Okay.
So I'll do the number of hours. So do the numbers of hours, days that emergency rooms are on diversion correlate at all to these metrics on hospital admissions? Does the diversion rate predict higher admissions? Are the authorities allowing emergency response to suffer while waiting to act on a higher admission rate? So diversion just means you're not taking patients. And I know, Stephen, you're very familiar with this kind of stuff. So this just basically means once we get to, because diversion was something that we weren't allowed to go into during the surge of 2020 in the wintertime. They weren't allowing us to divert patients to other hospitals. They weren't allowing many hospitals to declare internal disasters. I think we were able to declare an internal disaster just a couple times during 2020 surge of the wintertime. Now, for this metric right here, it's 10% of the hospital beds within LA County that are occupied that puts us at high. Now, all these specific stats that you're asking for, I personally don't know because I'm not necessarily in administration, but I know from personal experience, we only declared, I was trying to actually organize with people to declare an internal disaster for my hospital that I was working at because we were in an internal disaster and they were not allowing us to declare it. So I was trying to do research on like what more we could do to try to declare it, to shut down the hospital for a few days. But that only happened, I believe, over the course of a couple days during the surge where LA County was able to shut down and where the hospital I was working at was able to shut down. Yeah, I'm sure they're known. I'm just not, I'm not administration. So I don't handle, I don't handle kind of coordinating that necessarily. I'm more of just a floor nurse. I show up and I do that piece, but I think that's a really good question and we can keep it, maybe Lisa, I don't know, Bita, do you have diversion stats at all for hospitals?
I think they've taken into consideration what that threshold should be based on this from examples of the past. So I don't know exactly what the threshold is, but yes, the threshold does take diversion, rates into consideration. But I think the key, like really important here though, is this issue of structural racism and how it intercepts with the hospital. So regardless of what their threshold is, in a situation where they might underestimate that threshold, as in like have hit that threshold, but in this case, because of how the surge is and all the factors that Jamie is talking about in terms of the healthcare workforce and capacity, if all these things don't go out as predicted with this threshold, then the people who are going to be impacted the most when it comes to being rejected from emergency rooms or getting poor care on the inside because the system is strained, right? We know that's obviously going to be, predominantly like Black and Brown communities, right? And Black and Brown hospitals. And so there's also the factor of, I think Jamie spoke to this a little bit, but can talk about it more. What does it mean to be in a hospital that's surging and with these metrics when like there's so much segregation in healthcare across the city? So not everybody is using the same hospitals. So what does that mean then, like in a situation where, you're making countywide thresholds, but the burden of that is not evenly felt across the county, right? Yeah.
Yeah, exactly. I think that's an excellent point, Bita. Any other questions? Because I definitely wanted to keep us moving. We have a lot to talk about tonight. Okay, I'm going to pass it to Lisa.
Thanks, Jamie. Hi, everyone. My name is Lisa Patrick Mudd.
I actually do work. I've been in the public health emergency preparedness, response and recovery field since 2016. I do work for LA County Public Health, and I do want to say that I am not presenting here tonight in any official capacity. I don't represent the department or speak for the department. I'm just here as an activist and public health professional who's really excited that people, want to talk about these solutions and talk about, how we can take measures on our own to protect ourselves and our communities from COVID, regardless of what, metrics CDC posts, regardless of what, the state or LA County says are the thresholds of when they'll require masking, for example. So one thing I just wanted to talk about real fast is variants, because I think, we all know these surges, they come in waves. They're usually in the fall, they're usually in the summer. And why are things bad and why are they good? And, what are all the different factors that are sort of informing these surging numbers? So I just want everybody to think real fast, kind of back to the beginning of COVID when we had Alpha, Delta, these dominant variants that were taking place, and how as the virus has spread and, and mutated into different variants and sublineages of those variants, that's really when the opportunities arrive for, these new variants. So now before we had the Omicron and it was BA2, and that was the dominant lineage of the virus. And now we're looking at BA4, BA5, which are slowly becoming more and more prevalent, not just in Los Angeles, but across the United States. And so we're looking at those numbers increase. And if people are familiar with how viruses work, their structure, their only purpose in the world is to mutate and survive. So they're going to do whatever they need to do as organisms to live another day, infect another host. So as the opportunities for transmission to occur, which that's what's happening right now, those are really the opportunities that the virus has to mutate. And as more and more people are vaccinated, as more and more people, have become comfortable and things have sort of slowed down and people, were feeling safer being inside, feeling safer taking masks off, because they were vaccinated, because, they felt like ready to travel and whatnot. Those factors, just more mingling, more people, more activity, not masking. These are all opportunities for viruses to spread. And I just want to check in real fast with my epi, folks and make sure I didn't completely destroy that, but hopefully it's all right. Do you have anything you want to add to the variant story? Okay. We did want to put in a another quick clip of public health, just giving a little more context to the discussion of the variants and how they're in LA County. So Bita, if you could please play that one for us. Thank you.
100% of Omicron since then. Next slide. On this slide, we're just showing the variants and subvariants of the virus detected in LA County since November of 2021. That's deltas in green, and the rest of the colors on this slide represent the subvariants and sublineages of the Omicron variant. As you saw in the last slide, Omicron rapidly became the dominant variant at the beginning of the winter. During the first part of this year, we learned that subvariants of Omicron were even more infectious than the original Omicron to varying degrees. In the first months of the year, we detected the Omicron subvariant BA.1 that you could see in dark purple, and its sublineage BA.1.1, that's the lighter purple. In the spring, we detected another new Omicron subvariant called BA.2, and its sublineages BA.2.3 and BA.2.12.1. All you see here in different shades of blue. Most recently, we're tracking new subvariants of Omicron, BA.4 and BA.5, and you could see those in red. Looking back, it's clear this pandemic has been fueled by the ongoing rapid change in the COVID-19 virus. Each new variant and subvariant brought changes in viral patterns, such as the reproductive rate, the ease of transmission, and the location, timing, and sizes of our outbreaks. Each new variant and subvariant has challenged us to uncover the significance of these changes, how they're going to impact LA County, and what we'll need to do to protect everyone in LA County. And we, we are projecting that we'll continue to see similar patterns in the near future. The next slide. And as the variant.
So thank you, Bita. I saw a question in the chat about what makes it, what's the difference between a variant, I'm sorry, was a variant and subvariant? Is that what the question was? Oh, this new variant versus subvariant. My understanding, I believe, Bita, correct me if I'm wrong, it's due to as they sequence when they run tests and they sequence the virus, it's based on a certain number of similar, oh, Bita, can you help me?
No, you're absolutely, when they sequence the genome, and so then therefore they know what proteins are coded based on what segments of the gene and what the structure is of different parts of the virus, depending on the types of changes and where those changes are, that's where you get the different classifications. But I also think, and this is outside of the scope of my expertise, it also has something to do with temporality and also geography. So how soon something's discovered, and also where in terms of other variances that are there. So in addition to the sequencing, I think that there's other data that's taken into effect where things can get corrected in the future about what people think is happening in the moment. So you might, for example, see that some of these things that are subvariants might later on be say, no, this was actually a new variant based on like additional data that we got, for example.
Great, thank you so much. So moving along, one thing I did want to mention, as you know, we're thinking about new subvariants, we're thinking about, okay, so I'm vaccinated, my family's vaccinated, but we're still susceptible to, you know, post-vaccine infection. And now that there's different variants, that could mean maybe, you know, even if we had COVID before, we could still be susceptible to getting it again and passing it around again. So one thing I wanted to talk about real fast, I realize we're running on time, is, you know, the masking question. And, you know, the mask mandate again comes into effect once these certain metrics are made in a community. But again, there's nothing that prevents anybody, any group of people, household, community, from just masking when you're going out in public. There's nothing that says that you can't do that. You should definitely feel empowered to do that. If you're looking up at the numbers one day and you're like, oh my God, wow, we're already at 8%. But nobody's mandating anything except for on transportation or in healthcare facilities, which those are existing still. But you know, you can say to yourself, wow, this feels like this is getting serious, and I personally want to decide I'm going to wear a mask because I care about, you know, my elders, my neighbors, my grandparents. I care about my immunocompromised family, people that I could look at them and maybe not know that maybe they weren't able to get vaccinated, or maybe they chose not to get vaccinated, or maybe they have some severe health problem that's not visible to the eye. You never know what people's situation is and what's going on with them. And so as an act of compassion, as an act of, you know, creating a culture of caring for one another, masking is really that. It's fairly simple action that you can take that really does make a very significant difference in preventing spread of COVID. So I just want to show one quick thing so folks can see the LA County site. I'm just going to take you through real fast and show you. Bita, can we stop sharing your screen real fast? Thank you. And I'm going to share how you get to the table so you can see. So you would start on, this is the home page for public health. It's not very intuitive to find. So you're going to go to the COVID tab, which is a drop down. There's all these, you know, links, information, flyers, information about ISO quarantine, different guidance, et cetera, et cetera. And then you're going to get to data dashboards. And if you click on the daily cases, testing, hospitalization rates, that's really where you're going to be able to see this data that Jamie was talking about earlier. This will show you the daily test counts during the week, test positivity, death rate, hospitalization rates, and other information. And you can even look down, and this drop down can take you to a number of other data pages as well. One that I did want to make sure that I showed to you as well. Sorry. Is the post-surge dashboard, and this is what Jamie was really showing. So this is a really good one to check out too and just become familiar with. It's a lot. It's a lot of text. It's, you know, I don't know, it's too much, but it's something that I would, you know, suggest that you just take a little bit of time and kind of go on there and look around and see and just start familiarizing yourself with it so that you can make those decisions, you know, for yourself and talk to your community and talk to your friends and family about when it's right, you know, when you think is the time to start making safety precautions that are really going to help.
Can you go down real quick, Lisa, on the graph on the web page?
On this one?
Oh, no, go up. I'm sorry, go up to the top.
Yeah.
So just real quick, this is where you see that it says medium, that we're at medium. And then to the right, you can see where it says that there's 337.43 cases per 100,000. And then the next one is talking about the admissions. The next number right there, 7.3, is talking about the number of people that are being admitted per 100,000 into the hospitals. And then the number next to that is 3.5. And that's telling you how many beds, how many percentages of beds are being occupied by COVID patients. And then just below that is the different metrics that you're seeing again, and then just kind of explaining to you what is considered low, what is considered medium, and what is considered high. And then I see a couple questions. Is it okay if we go to questions, Lisa, real quick? Okay. I'm going to answer the one in the chat, and then I see you, Audrey. So Stephen, they have, Barbara Ferrer actually goes through the sewage testing on the actual briefing every Thursday. She'll talk about the various levels and the different sewage testing that's happening. So I'm not necessarily an expert on that, and I don't want to take up too much time, but offering a resource that in those media updates, she'll actually talk about the levels of COVID-19 that are being detected in the sewage systems.
I also just posted a link in the chat to a couple of graphics on data on sewage testing in Los Angeles County.
Cool, thanks, Breann. And then Audrey, I see you had a question, and then I think we're gonna have just a quick conversation too.
Yeah. I've been so frustrated for so long about the what I saw as cowardice by our public elected officials and appointed officials for not returning to in-person meetings because they just don't want activists to be looking at them in the face. And I'm finding increasingly Zoom approaches are just wearing very thin on me. But maybe, I mean, all of this presentation is making me think, it's not that I don't think they're cowards, but that maybe I need to give that process more grace, and that there's some good sense in not returning to in-person meetings at this stage. Is that true, do you think?
I think that question, actually, I'd like to throw it out to everybody now, because that was the conversation that I wanted to spend like 5 minutes having with everybody. But what are the community facing solutions? Like, what is our responsibility in knowing, and first, and so just kind of switching now, and thank you, Audrey, for really opening this up. But what is our responsibility to even understand this information? And it's not like, I'm a registered nurse. Honestly, hanging out with my public health folks is where I've gotten better. And my kind of desire to understand more about COVID is how I've gotten better at reading the graphs, understanding what the numbers mean, right? So kind of throwing it back on each other, what is our responsibility in understanding this stuff? What kind of risks do we want to take? And if we are taking risks, what kind of mitigation tactics can we put in place that allow us to not be, to allow us to be as safe as we possibly can be? So I would put it to you, Audrey, like if you know that we're at high community spread, You know that what would be the safest way that, like, what is your thoughts? How do you feel that we should, when we should be meeting, when we shouldn't be meeting, you know? And if we were to meet, how should we be meeting? You know, these are, I think these are questions now that as a community, we need to start to grapple with and kind of start demanding certain types of kind of mitigations for ourselves. So I'm curious, what is your thoughts right now in thinking about what the safest thing is for you or for your disabled friend or for, you know, compromised person or for, you know, even for the social justice that you're fighting for, you know? What are some of your thoughts about that? I'd be curious to hear.
Well, I mean, I had a friend text today, someone that usually brings snacks to our weekly protests on Wednesday afternoons, saying that they just tested positive. I mean, it's not happening in huge droves, but there's a pretty constant stream of new infections. And it's just, I don't even know. I'm a follower, I think, you know, because a part of me wants to never see a mask again, but, you know, and it's a weird world because we mask up every Wednesday at this outdoor protest. Everybody's pretty much still masked. And yet, you know, you see in the grocery stores and you see, you know, all over in restaurants, you know, people relaxing and going mask free. And so if I know somebody is possibly immune compromised or especially vulnerable, I would always, you know, wear a mask. And I do, if other people are, I will wear a mask, but it's really, it's just a weird world out there right now that there's so absolutely no consistency, you know, and yeah, so I'm not a good arbiter for that, I think.
I'm wondering if anybody else has, and I see Steve, you have a question, and I'm going to get to that question. Thank you, Hamid, for flagging that. I just want to like kind of open it up now. And how are people feeling about, you know, about masking, about the activities they're doing, about, you know, realizing that we're at high transmission, yet CDC hasn't mandated the mask mandate. How are you making your decisions? Like, what advice do you have to each other as a community, as a collective? You know, is it easy to understand this stuff? Is it not? Are we still struggling? I'm just curious to know where folks are at, because one of my friends gave me the advice that it's now on you all. You know, I can only do as much as I can do when you show up in the hospital, but now it's on us, right? It's on us to actually really start creating the conditions and demanding conditions, you know, that we want to see. So any thoughts at all?
Yeah, I think Michal have their hand up.
Yeah, just I think as someone who is high risk and got COVID and had it really badly when a lot of people were talking about like, just it's so mild now. I think I feel a general frustration that these decisions have become so individualized, and I think it's putting all of us in bad positions. I think, you know, I think not only it's like stress, it's creating really dangerous situations for certain people, but I think it's also creating like interpersonal tension, in part because a decision that can be sort of like a decision to just say like, we will protect each other and take care of each other, regardless of what our own personal status is, sort of feels like it becomes a reflection of people's values. And I think I really try not to make assumptions about how people are feeling about things, given whether they're masking or not. And also, I think sometimes it feels hurtful. Like, I hope that doesn't sound strange. It feels like people have forgotten a little bit about what's going on. And yeah, I feel, as someone who is high risk, but also working with folks who are incarcerated every day and are super high risk too, I feel confused about, and not confused, but I feel like maybe unshocked about the fact that it feels like there were some moments in COVID where like there was a sense of moving into a greater understanding of what mutual care looks like for each other. And it feels like we are now, because sort of the state has condoned this really individualistic orientation, we're now slipping back into, well, like, I'm not sick or I'm not bound to get sick. But I think that both puts other people at risk, and I think is just also socially isolating, and feels like emotionally sad sometimes to feel like you're trying your best to be in the world, and also are not necessarily seeing people externally express that they care through action. So that's all to say, yeah, I think if anything, we learned that we could do hybrid in COVID. And I think that there is a real loss for people of not having like in-person social connection, for sure. And I feel frustrated that there are actually some state meetings meetings that people, now you can't call in anymore. And I'm like, we did this, like, y'all figured this out. You figured out how to do comments in person and on the phone. Why can't we continue this in the spirit of actually making all of these spaces more inclusive? So thank you for listening.
I don't want to mispronounce your name, but I see your hand raised, and it's Q-U-O-C.
Oh yeah.
Could you help me?
But then, some people know me as Q, but yeah, it's Squip. But basically, just to compliment, what Mienah said, I think, I think the overarching message, what I'm saying, is like, and not in like a corny, what I'm saying, cliche, co-opted way, but like, it's capitalism that is really like steering, what I'm saying, the trajectory of the ship, what I'm saying. And like she talks about individualism, how like it's not much different, what I'm saying, like with cases, what I'm saying, rising or lowering, what I'm saying. It's like in the beginning, what I'm saying, it's like in the nature of capitalism, like social Darwinism, what I'm saying, it's like a crabs in the barrel, what I'm saying, mentality, where it's like, well, I'm straight, what I'm saying, and it almost feels apocalyptic, what I'm saying. And it's like we gonna fight for ourselves, what I'm saying. And I think that's like the overarching, direction of like how we treating this, whether things are getting better or not. It's like, shit, as long as I'm good, what I'm saying, as long as I can get my toilet paper from Costco, or as long as I can, go shopping, what I'm saying, and get Hennessy bottles and get, what I'm saying, woo, what I'm saying. I think that's like that's the destructive, what I'm saying, theme, what I'm saying, within like the way we've been handling, what I'm saying, the pandemic, as we compare it to, other nations who've been able to, what I'm saying, basically, flee, what I'm saying, some of these, exacerbated situations, what I'm saying, in terms of like the way the health crisis, what I'm saying. And I feel like, she was talking about how like, it's individualistic, and it could be solitary, it could be lonesome, and there's tension, what I'm saying. But I think, because we kind of have like this crabs in the barrel mentality. And I think that, if anything, if this is really apocalyptic as it seems, what I'm saying, and as awful and disturbing and detrimental, what I'm saying, for not only us and, but like, our elders and people who are, at risk, I think like, this should alarm us, what I'm saying, just as much as, things in the past, what I'm saying, when it comes to, what I'm saying, George Floyd, when it comes to, the Patriot Act, whatever, right? This, what I'm saying, I think just like the nature of capitalism, what I'm saying, it just perpetuates, what I'm saying, this like, bare minimum activity to like, what can I do? What I'm saying? And I feel like, that if this is really as serious as it seems, you know what I'm saying, we should gather, you know, we should organize, we should collect, you know what I'm saying, even if it's through distance, even if, you know what I'm saying, like, but I think, we can't just start, treat this like it's a survival of the like fittest, you know what I'm saying, type game, you feel me? Because that type of game is gonna lead us, you know what I'm saying, to our own self-destruction, you know what I'm saying? And it's like, by capitalism, either we end capitalism or capitalism is gonna end us. And in this case, capitalism is ending us, you know what I'm saying, physiologically, you know what I'm saying, like, in terms of our public health, you know what I'm saying? And I think we should, like, recognize that, like, this isn't a time to, you know what I'm saying, just think, how am I, I'm not immunocompromised, and I'm able-bodied, and I'm young, and, like, you know what I'm saying, you should use that, you know what I'm saying, for the collective, and you should try to bring other people who are well and you know what I'm saying, have like this anger, you know what I'm saying, towards the system, you know what I'm saying? But you feel me, that's just my take on this.
Thank you. And then I'm going to take one more question. I think Steve had their hand raised. Thank you so much for that. And then leave you with just a couple tips. I don't want to just leave us with, oh my God, test positivity is out of control. And so go ahead, Steve.
Yeah, no, I just wanted to sort of share my reflection as I was hearing you speak and Lisa speak. It really feels like it's just a continuing evolution of what the coalition's working against, just in a different, more deadlier manner. Thinking about how it really is about investing, and it's really about recreating new systems of care and sort of reinvesting resources or taking away from sort of how resources are invested in our communities and reprioritizing them. So I really sort of hear that as we're talking, but I also sort of think and sort of I'm hearing like all the other sets of information that goes into it, right? So everything for how the data is collected in terms of originally around sort of contract tracing and sort of the lack of healthcare provision and sort of how that is sort of equivalent to sort of the communities that you live in and sort of what you're able to access in. So I feel like I just wanted to share, like, I feel like as I'm hearing this, it's a lot about just another evolution of how we're having to fight something. But now, instead of fighting to not be in jail, not fighting to sort of not, I'm sorry, instead of fighting to not be in jail, now we're fighting to live, and literally just fighting to live because of COVID-19 and sort of the response that the state has provided.
Well, thank you, Steve, for closing that off for us. And so, so I just want to, just to kind of go back to what Audrey was saying, I think where we're at right now and some of the things that a lot of folks are implementing or that we should be implementing at this point in time is a lot of indoor masking. So we're at wide community spread right now. And we need to really, first, I'm only going to talk about shared spaces, because I don't want to get into debates with people about whether or not they should be going indoors to eat dinner, whether they should be going to indoor concerts. But what I really want to do is say, as a community, we should be protecting the spaces that people need the most. People need to shop for food. People need to shop for clothing. People need to get on transit. People need to have access to parks. And we need to think about those spaces as spaces that are for everybody. And thinking about when we're at wide community spread, we should be thinking about when we're indoors, we're wearing a high quality mask like a KN95 or a KF5. What is the KF one? I never remember what that one is. Lisa, do you remember the KF or something?
I want to make a bad joke and say KFC, but I think it's the KF94 is I think it's KF94.
Yeah, KF94, KN95s are more comfortable in the N95s. But right now, in all those communal spaces where everybody needs to be in, we should always be masked because it is widespread. Thinking about ventilation in your home, one of my biggest things is that if you have to gather indoors in your home with people, start considering doing antigen tests before people come over. Think about the size of the space, of the size and the amount of people that are coming into your space. Even if you're outdoors and it's crowded, you can still get COVID. So really right now is the time to have those high quality masks on and to really be thinking about who your neighbor is and how you can be supporting them so they can get to and from the places they need to get to. So we went a little long, but I was really happy to have this conversation with everybody. I think I can speak for our team that this is the kind of stuff and engagement we want to be having with you all. We want to be knowing not only how you're doing, but sharing with you information and then also deconstructing some of this information. So to do that, I'm going to pass it over to Bita, Mienah, and Breann. So thanks, everyone.
I think the conversation that you all had was like the perfect kind of like meta, like big picture of what public health is and what public health is unable to do. Because a lot of this conversation around like individual decision making in countries and states and places and communities where you have a strong buy-in and understanding of the difference between, say, public health and medicine, you also don't have these divisions like we're seeing right now here today, because there's an understanding that like actions and actions that a person takes has an effect on the collective, and therefore we need to put some practices into place in order to protect those who are the most at risk, right, in a collective. But in this country, this is the setup, for our kind of this section. In this country, there's always been this tension between like the public health we know we need because we need to be thinking collectively and making decisions that are the best for the group, that take into consideration what the impacts are on those who are not either, that they don't have like the resources or are unable to, to withstand, right, whatever, practices, right, that we have, that we would take as an individual, right? All these types of decisions and this type of logic and this type of commitment is what we like to say is like the best version of public health. Like if we had the kind of public health that we really needed, that's what we would see in place. But the reality is there's public health as a set of like principles and logic, and historically it's been used and operationalized in a certain way that doesn't promote as much of the benefit of it as it does the harm. And I'm going to go through some examples of that in a second. But the other really important part here to talk about when we're also getting at what Jamie was saying when it comes to workforce exhaustion in the workforce, and what Michal and Kwok, I hope I said that correctly, Kwok was saying that when we are caught in this place where we're making decisions that are like obviously like have eugenic implications, right, are about some sort of like social Darwinism and are really not thinking about the collective, you have to look at like what's the workforce that would be able like that would be there to make that kind of like decision, or to be able to be in place to support the the opportunity for that collective decision making to go in a way so that the consequences of putting those practices into place don't affect those who have the least amount of resources the most, right? Like, for example, if we think about like the stay-at-home orders that we had initially in the pandemic and how not everybody could, meet that because they had different types of occupational considerations, or just, for example, the healthcare and the care workforce could never stay at home, right? Because, they're needed to be in places, whether they're in nursing homes, right? In people's homes providing aid, or in hospitals and clinics, right? When we think about that workforce, there has never been a commitment to really appreciating that workforce or investing in it. And over time, as we've seen more crisis and kind of like neoliberal changes implemented across many different cities in the United States, and specifically the privatization and the gutting and the cutting, right, of like departments that provide essential services, public health has always been one of the first things to get cut. And I have an example here to kind of give that context for why, it's part of the reason why we always come to hear this information. We're so excited to hear, and we're like, well, why don't I hear it, right? And then we meet somebody like Lisa, and we're like, oh my God, like, how many of there are you out there, Lisa? And Lisa's like, dude, there's 0.3 of me that are out there, right? Like, getting back to Jamie's 7.3, right? Like that there's really never a full appreciation for how little the workforce is in something that is so important. So if we think back to Detroit, and we all know, Detroit, Michigan, like we think about water, we think about the Flint, Michigan crisis, we know that there was, that it's a very particular important history in Detroit in terms of like trying to dismantle social services and privatize, right? So many of like those state functions with, you know, huge consequences for public health. If we think about, for example, the water supply, right? And what happened there. But in Detroit specifically, in 2008, the city had 700 public health employees. In 2012, it was reported by NPR that there were only 5 remaining. So they took a 700-person workforce and they gutted it down to 5. And then since 2014, that number, right, was slowly starting to be built up so that in the middle of the pandemic, they had reached 270. So going into a pandemic, they were operating at 1/3 of their capacity. If we assume that that 700 original number was even the right number to begin with. So when we're over here talking about individual decisions and like what exactly is public health and what's going on and how come I don't have this health literacy, we have to really appreciate the fact that like, who does the public health work in this country? One, it's by like, if we're gonna say it's done by somebody who works in public health, that's a really small number of people, right? Like when we even think about the most important bodies of history and science in this country, there's a National Academy of Science, Medicine, Engineering. None of that says and public health, because public health in this country was always imagined as only the policies that would determine the movement of people. And we know what people they were talking about, right? When we talk about slavery and enslavement, right? People African descent in this country. When we're talking about the movement of goods, transportation, right? Across transportation and air. Public health was really only regulated when it came to movement of these things across state borders, right? Like that's when there was like, okay, now we have to have some understanding here. If we're going to be the United States of America, like what moves between our states and what's those policies that regulate it and what are the standards out here eventually for how much polluting we can do, what's the carrying capacity of the earth for these commitments we have to like capitalism and extraction and exploitation, right? Like these are the places that you saw public health coming into effect and being codified in this country. And so then a lot of what we call public health work happens by people who are MDs, happens by politicians, urban planners, right? People like in like the legal sphere, like people who don't have an MPH or have not studied, right? Like public health or the public health sciences. And I think that's really important to set the context then for some of these historical examples that we're seeing, because what we're going to see is that in the name of public health, a lot of stuff has happened. But when we're talking about the public health workforce that's organizing a response to maybe resisting against that, like in many of these cases, the people that are doing that work are nothing more than an extension of the state, right? Coming into a neighborhood and doing that. Okay, let me share my screen so I can get into the slide presentation. Give me 1 second. And tell me if that's not right. Tell me if this doesn't work. Can you see my first screen? Okay, and then I'm gonna really need folks to help me stay on track in terms of time, but I'm gonna go fast. So what we're doing here in these next couple of slides are giving some resources for people who would want to like learn more about when we're talking about public health being an applied science of the state. It's always going to be something that's reformist because its entire intent is to do what the state needs it to do in terms of management of populations and communities. So even when it comes to the science that it deploys, that science is always based on a specific type of question. And that question is always around, how do we maintain the level and the health of the population? How do we maintain the population health at a level that ultimately still allows for white supremacy, heteronormative patriarchy, and capitalism to do what it needs to do, right? And this is extremely important because ultimately, and this is what part of the reason that Jamie has been so clear about why we all need to come together and talk. Ultimately, we know that people need to be cared for. We know that we can't make these individual decisions. We need to think about our collective health, but we're caught within a certain framework and logic. And when we ask the state for these resources, because this is how the state has always thought about, contextualize and operationalize its public health in the country. On this slide, we have 3 examples from the 3 textbooks that you see here on the left. The first one has to do with public health surveillance in San Francisco, specifically the Chinese community around cholera. Here, public health used mapping and data collection to produce evidence that showed Chinatown in San Francisco was disease producing and a source of risk for cholera and other infectious diseases. And specifically that risk that it was posing was a risk that it was posing to the healthy and white surrounding community. In this book, Nayan Shah also does a really fantastic job of showing how maps, I think folks, might know know Snow's work on cholera and how he used maps to be able to detect where outbreaks were coming from and what the sources of those outbreaks are coming from. You see a very important public health tool used in order to collect information about Chinese businesses, right? To do counts on on demographic counts of household, right? Which of the, who was living where in terms of who was single, who was married, right? What were their ages? And so that's a fantastic resource to learn more about that type of surveillance in public health. The second one is Los Angeles Mexican community. It has to do with Los Angeles Mexican communities, tuberculosis and syphilis. And in this book, Natalie Molina takes us through how during the 1930s, Mexicans in LA County were marked as a group whose bodies were illegal and ill, and therefore a risk of disease transmission for the innocent and clean residents, right? These are all stories racial stories as old as time. At this time, the Los Angeles Clinic and Hospital Association notified Mexican patients that if they discontinued their syphilis treatment, they would be subjected to deportation. The most common reason given to deport Mexican patients in the hospital was tuberculosis, even though there are records that indicate that the person who was deported didn't even have tuberculosis to begin with, right? And then the final example we have here is about the Black Panther Party and coalition activism and the study of violence by Alondra Nelson in Body and Soul. This talks about how in response to protests and urban uprisings in the early 1970s, the UCLA was proposing to the state to build a center for the study and reduction of violence, to explore the biological roots of violence. Here we could replace that with behavioral roots of violence, right? And that would just be today. Basically in that book, in that chapter, Dr. Nelson does a fantastic job of talking about how the center was literally being put into place to apply a health model to looking at the problem. And so it was one of the reformist and progressive solutions, but obviously the Panthers and their coalition were like, no, they smelled this a mile away, and they organized and they were able to stop the building, right, of the center. So we move out of history and we go into more contemporary examples. A couple of these examples are pulled from the Unmasked Impacts of Pandemic Policing. And here are the reference for it is on the left. And the other ones come from news articles. But in the first one, it talks about how in Detroit, specifically targeting Black communities, facial recognition software was being thought of as a potential public health surveillance tool in order to see who was and was not complying with emergency orders. And that technology, the penalties, right, from that included fines of $1,000 up to 6 months in jail, right? Another example here is an example of COVID-19 and stop and frisk in New York City, targeting Black communities, and where police enforcement resulted in, out of 40 people that they were arresting for non-compliance with the orders, 35 of them were Black, right? Obviously showing who they were targeting and who this surveillance order was weaponized against. Then we have an example in Louisville, Kentucky with ankle monitors. And then finally, we have a final example in the education system, where this last one is very interesting because in order to enforce COVID policies, they instituted something like see something, say something, with then disciplinary actions being put on that person. Like, if you were there and you didn't say something, then you might possibly also, see some disciplinary action because you should have done your public health duty of saying something because you saw something, right? So these are all very these are portals into a future, right? Because we know we will have more pandemics. We know we will have more crisis. We will have more public health orders that will need to go into effect, as Jamie and Lisa have so thoroughly described for us earlier, right? We know we will need these things, but then when we talk about the enforcement of it and public health surveillance, we also know there's a potential for it to be weaponized. Okay, I'm going to stop right here. And Mienah and Breann are going to take over and talk about another contemporary example of public health surveillance, Title 42.
Thank you for that introduction, Bita. My name is Mienah, and I'm calling in from Seattle, Washington. And so I will be giving a very bird's eye view, high level overview of Title 42, and it'll be really clear, but I'll just say it to be upfront. I'm not a lawyer, I'm not a legal scholar, legal expert, so I will be a legal analyst. So I'll be drawing on hoping that those of you with those skill set and or more background on Title 42 would join this conversation, and please correct or clarify anything that I present here. But I am presenting just describing a kind of brief overview of Title 42 from a health equity perspective. And as Bita described, I approach this work trying to pursue, health equity and social justice work, recognizing that I work within these systems. I work with the tools, the methods that, as she explained, uphold white supremacy, uphold the notion of American exceptionalism, the neoliberal ideology, the patriarchy, all of these problematic practices that ultimately threaten and undermine the very goals of equity and social justice that drew me to this career path and this field. But that's why these spaces are so important and critical for us to have these conversations. So again, just a brief overview of Title 42 to provide some context. Since it was enacted, since we have the first data on it in April 2020, the first full month after Title 42 went into effect, since then to March of this year, there have been nearly 2.9 million encounters with migrants along the US-Mexico border. And nearly 1.8 million of these encounters, or approximately 61%, have resulted in people being expelled under Title 42. And this includes nearly 16,000 unaccompanied minors. And the roughly 1.1 million remaining encounters ended up being apprehended under Title 8. And estimates that we have show that the number of people being denied entry into the US as a result of Title 42 has steadily increased on a monthly basis since it was enacted. And so what is this law? What is it not? Just to, contextualize this within the history that Bita described, is that timing is really key when examining the motivation and goals of this policy and what it means for public health. So COVID-19 was declared a national emergency on March 13th, 2020, and only 7 days later, on March 20th, Title 42 was introduced by the same Trump administration, which allowed the closure of US borders to asylum seekers, and was introduced and justified as a public health measure for mitigating and preventing the spread of COVID. And so essentially under Title 42, the Border Patrol is authorized to turn away and expel asylum seekers, unaccompanied children, and non-citizens at the border. And it refers to a very rarely used section of dating back to the Public Health Service Act of 1944, which what that law did was empowered the federal government and health authorities to prohibit migration into the US if it was determined that doing so would prevent the spread of contagious diseases. However, what's critical to note about Title 42 is that this was implemented without any evidence suggesting that there was a significant concern regarding infectious disease or COVID specifically, that there would be any kind of improvements in those outcomes from banning asylum seekers or migrants from entering the country. And in fact, Title 42 was met with disapproval from authorities and experts at the CDC. And so this policy supersedes statutes that protect children from human trafficking, allow migrants to seek asylum, and prevent persecuted individuals from returning to unsafe conditions in their home countries. And I do want to provide some updates. So that was a background of kind of when it was enacted, but there have been some updates since then, since March 2020, including an update in February 2021, where the CDC exempted unaccompanied children from expulsion under Title 42. And so it's a broader statute with implications beyond the application that I'm referring to and how I'm operationalizing it here in terms of refusing entry to migrants during the pandemic. But for today's presentation, that's the application of it that we'll be focusing on. And so, as I mentioned, it supersedes existing laws that could provide some level of, any level of service or any kind of legal support or protection for asylum seekers under the guise of strengthening public health surveillance. And so this is critical because this is an example of what Jamie and and Bita were talking about, how public health messaging and goals can be co-opted by the state to expand the power of the state that we know over history has done harm and continues to harm communities of color. And this is how I came about to partner with the coalition, is because of these systematic ways in which public health methods, tools, data, language are being used to weaponize, are being used, co-opted to weaponize communities and directly undermine the goals of health equity that the field of public health claims to be charged with pursuing. And so what are some of the implications of this, of Title 42 from a health equity perspective? And there are many. I'm just going to kind of briefly list a few of them, but just take into consideration that we're still learning what these implications are. And given my training and outlook on a life course perspective, we will be, the implications and the harms that this will have for threat, the harms this will have for health will be ongoing. But as of, within the last 2 years, there's been widespread concern on the impacts that this law will have on the health, legal rights, and human rights of migrants and asylum seekers. And so a brief overview, before I go into a brief overview of those, it's critical that we consider the conditions and processes that these people have undergone before even getting to the border, before the implications of Title 42 on their health. We have to consider the toll on their mental health, as well as indicators of social and emotional well-being as a result of the migration process and the trauma that people have endured before even initiating the migration process. And these factors impact a wide range of health indicators, but they're not often taken into account in traditional public health or epidemiological research on migration. Rather, our field takes a really narrow approach of just a snapshot, or what we call cross-sectional, analysis of health behaviors and health outcomes post-migration. So I just wanted to point out how important it is that our field, really interrogate and challenge how we have grown comfortable and kind of complacent in doing our work by really taking a life course perspective, one that factors in exposures that impact health in the countries of origin and throughout the migration process. But just to document what's been reported in the current situation is, Title 42 has obvious legal implications in that it has created due process violations, and migrants, except for those falling into those specific exempt categories, can no longer access the US immigration system. They don't have their due process rights. They're being expelled without notice of this expulsion process, without a fair hearing, the right to present evidence, or even the opportunity to seek legal counsel. And the Border Patrol is not even making them aware of their rights. And what does this mean? This means that thousands of people, including vulnerable subgroups, such as young children, infants, older adults, pregnant women, persons with various ability statuses, are left with nowhere to go, forcing them to, with options such as to return to the countries that they were originally fleeing from, and back to those precarious conditions. Or their only other option is to congregate in these kind of encampments or refugee camps. And I believe there's a slide that has a picture of that. And so, within these settings, there's a scarcity of their basic needs being met: food, water, shelter. There's an increased risk of reported kidnappings, incidents of torture, rape, sexual violence, and family separation. And it's really important to note, that children, as I mentioned, are present and particularly vulnerable to these exposures and experiences. And again, we can't, this is not, we have to keep in mind this is all taking place within the context of a pandemic and the ongoing variants. And they're left with clearly no opportunities to physically distance. And those that are not along, in these encampments or refugee camps are those who are in detention centers. There are increasing reports of the conditions that they're being forced into, with limited and inadequate testing and access to vaccinations. And obviously, it's made impossible for them to physically distance there as well. So this law, contrary to how it was presented and justified, is in fact increasing the risk of exposure to and the spread of COVID. And another health outcome is that the number of migrants trying to enter the US has actually steadily increased over the last 2 years since Title 42 was enacted. It jumped from 7% in March of 2020 to 40% in October of 2020, and it has steadily increased every month. And this has also coincided with a stark increase in the number of deaths along the border. So as problematic as this data source is, I think it's safe to assume it's a gross underestimate, but the Border Patrol has recorded the highest mortality rate of migrants dying during attempts to cross the border since 2014, as recent as 2020. So we don't actually have more recent estimates, but we know that the numbers have increased since then. And we also know that the Border Patrol agents are increasingly using violent force on migrants at the border. And as I mentioned earlier, this has also resulted in family separations. So physicians, public health experts, human rights advocates working along the border have reported also increased risk of depression, anxiety, and PTSD among those expelled under Title 42. And the caregivers have also reported many mental health concerns among their children. And also, there has been documentation that people are not being offered the initial medical screening that the CDC guidelines actually recommend for people within the first 60 days of arriving in the United States. So those medical and health needs are also not being met. And so these expulsions are contributing to the cycle of toxic stress and trauma within these families. And these will carry negative implications for their health across life stages. And as I mentioned earlier, we're still learning more about what's going on, but all of this really, just further underscores why our field needs to prioritize qualitative research that focuses on directly working in partnership with community members and community advocates, and that emphasizes disseminating this information in real time. And this reflects a lot of the work that Bita has done and continues to do, and is a local and national champion of leading and supporting. And I know I'm grateful that I come to this space where all of this makes a lot of sense to you all in terms of the need to focus on this, but focus on these efforts. But I really want to emphasize that this is really not the norm or considered business as usual in the academic research enterprise. So it can be an ongoing struggle in these spaces to convince the need for this approach. And so that's why, coming to these spaces and getting grounded in the work that you all do and uplifting the voices and concerns of communities is really critical for those of us in these, operating within this academic research enterprise. And so that's my very brief overview of the background and public health implications. So I'll pass it on to you, Breann.
Thanks, Mienah. I'll try to keep it brief so that everyone can get out of here on time. If you could go back, yeah. So like Mienah talked about Title 42 and how it's a public health order. So the Biden administration has repeatedly said that it's a public health order and not a border security order. And therefore the decision to lift it must be made on public health grounds only. Biden announced earlier in May that in consultation with the Department of Homeland Security, the termination of Title 42 would be implemented on May 23rd to enable DHS time to implement appropriate COVID mitigation protocols, such as scaling up program to provide COVID-19 vaccinations to migrants and prepare for the resumption of regular migration under Title 8. That was a quote from the CDC. And this is another quote: after considering current public health conditions and an increased availability of tools to fight COVID-19, such as highly effective vaccines and therapeutics, the CDC director has determined that an order suspending the right to introduce migrants into the United States is no longer necessary. However, federal judge Robert Summerhays temporarily blocked the move to end the public health order and sided with the Republican arguments that the order was lifted in violation of the Administrative Procedures Act, and that it would hurt the states by increasing costs related to healthcare, driving licenses, and education. He also said it would increase migrant numbers at the border. And so, as the CDC said, they were preparing to resume regular migrations under Title 8. And if you could go to the next slide. So Title 42 has slowly been being replaced with Title 8. So while the percentage of enforcement of Title 42 has decreased, you can see here on the left-hand side that Title 42 has slowly been replaced with Title 8. But the overall amount of people being expelled or apprehended has grown. And so what is lifting Title 42, the impact on immigration and health? So Title 42 made up 80% of expulsions under Trump and about 51% under Biden. And so even if public health wins, like Mienah said, about all these public health stakeholders agreeing that Title 42 is not effective and is not truly a public health measure, we really need to investigate the solutions and alternatives that are being proposed. Current solutions posed include stricter enforcement of immigration laws to discourage unlawful and repeat entries through increased use of detention, expedited removal, prosecution, and asylum adjudications, and expanded border facilities. So over the last year, the Biden administration has rapidly expanded the so-called Alternatives to Detention program, also known as ISAP, the Intensive Supervision Appearance Program of ICE. And ISAP is an extension of incarceration, enabling the constant monitoring of e-carceration of immigrant communities. This electronic monitoring program now has more than 227,000 immigrants under constant surveillance as of April 2022, which is more than double of the number enrolled in the program when President Biden took office. Though ISAP is pitched as an alternative to the inhumane and irreparable ICE detention system, it is not an alternative. Instead, the program expands the carceral reach of ICE and bolsters all forms of immigrant detention. So this is just a screenshot of a report called Tracked and Trapped, which is about experiences from ICE digital prisons. And some of their key findings were that ISAP surveillance is a digital form of detention and the state's constant reminder of the lack of autonomy immigrants have over their own bodies and futures. They found that ICE poses enrollment in ISAP as voluntary, when in reality it's a forced choice between brick and mortar detention and digital detention. Smart Link, which is a technology used under ISAP, causes deep anxiety about ICE's access to personal lives and a constant sense of being watched, particularly for communities of color who are overwhelmingly subject to ISAP and targeted by all forms of law enforcement more broadly. They found that ankle shackles are painful, intrusive, and stigmatizing, unsafe and disruptive to daily life, and are another form of incarceration. They also found mandatory ICE and ISAP check-ins cause emotional distress, anxiety, and fear of retaliation. And lastly, that ICE does not conduct regular de-escalation reviews as outlined by its own guidelines, often ignoring them altogether, making surveillance a perpetually continuing reality. And then if you can go to the next slide. So from this report, Tracked and Trapped, there were also a few core demands. And these demands are really important to take into consideration and for us to really advocate for, because when, as we all know, like when one system is, being replaced by another in the way that things often go in the US, these systems are not, they're not for abolition, they're for reform, and that they often cause more harm and expand the carceral system instead of working towards abolition. So some of the core demands were demanding ICE in all detention and ISAP altogether. ISAP is not a trade-off for detention, and we demand that all forms of caging be rejected. We also demand that ICE immediately cease enrolling new people into ISAP and conduct large-scale de-escalation to release everyone currently subject to ISAP from the program. We demand ICE immediately cancel its contract with BI Incorporated and end any partnerships to develop new technologies for e-carceration, such as surveillance wristbands. We demand ICE and BI Incorporated immediately delete all data collected from the program and ensure any data shared with or sold to other government agencies, private entities, or other third parties is purged. And we demand that Congress reject the Biden administration's $527 million request for funding and expansion of ISAP and defund the program in all forms of detention. And so as we've kind of discussed, I'll just wrap things up quickly. Public health has historically been a state activity closely associated with the needs of national security and international commerce. This is particularly true with regards to emerging diseases, which were often framed as a threat to American national security, international development, and global health. I work particularly in the field of HIV, and in April of 2000, we saw this logic was applied to the HIV/AIDS pandemic when Clinton administration designated it as a threat to American national security. And that came after a National Intelligence Council report that called infectious diseases a, quote, non-traditional threat that would complicate US and global security over the next 20 years, endanger US citizens at home and abroad, threaten US armed forces deployed overseas, and exacerbate social and political instability in key countries and regions in which the US has significant interests. And so from those like key bullet points that were pulled out of this National Intelligence Council report, we really see like where the priorities lie in making decisions that, are being made, quote unquote, for public health, right? But in reality, their concerns are the US armed forces being deployed overseas and social and political instability in countries and regions that we have interest in, that the concern is not coming from a place of the people and communities and keeping each other safe, but it's coming from a place of ensuring national security and ensuring financial security and the goals of capitalism. And I really appreciated the conversation earlier about what that looks like in practice and what we're seeing today and in our local public health departments of the lack of support and the push on individual decision making, and also on the social Darwinism that was being talked about and the eugenics that was being talked about. And so this language really shows the way that public health practice is so closely associated with national security and international commerce, and how one of its key functions has been to protect its citizens against threats perceived as having an external origin, particularly with infectious diseases carried across borders. And this Title 42 is not new, like Dr. Amani went through the examples earlier of cholera and syphilis and tuberculosis. It's just another continuation of what we've been seeing, and just shows the roots of public health as a field, and the ways that public health is operationalized. And so with that understanding that public health treats infectious disease as a threat to national security and international commerce, we can see how this impacts the way public health responds to these threats. And these threats are often rooted in wartime logics to fight against the threat. And so we see then, with things like Title 42 and the pandemic policing, that we use these wartime logics, that it's like combat, and that it's not coming from a place of care, or like what public health, I work in public health, and what we like to believe, the work that we're doing, and the work that public health should be doing, the public health that I believe in, that is really not the root or the foundation, and the field and the way that it functions within the United States. And so I'll try to keep it brief. I'll pass it back to Dr. Amani to give some closing remarks.
I just wanted to end with, I think, two main take-home messages from our kind of contextualizing of public health history, and also talking about more recent examples, in the form of Title 42. We have both the way that public health is used, and its like tools are used, its science is used in order to secure populations, and that language right there should obviously, from pretty much everyone here, that language right there should just remind us of the conversation on policing, right? When we think about like who and what are police out there, right, in order to protect. So public health is about then organizing resources and people and putting into place strategies and recommendations in order to do that protection, thinking through what should be securitized and what is disposable, and also then what is a threat, right? In terms of that, that one thread of its thinking. This also comes into contact with post 9/11, with the contemporary like moments that we sit in when we're talking about abolition and alternatives to care, where the way that a public health model of looking at this domestic problem we have of, using too much force, or using, jails and prisons, right? All these things in order to manage, right, populations, as Ruthie Gilmore talks about, are considered disposable, right, or dispensable, right, by the state. So public health also then offers a set of logics and tools for doing that management. And the example we wanted to bring in terms of the tracked and trapped, and all and so many examples of the coalition's work, how they coincide with this, is that if it's not going to be a public health solution, they got another one, because the end goal is pretty much one of being able to manage and to get communities and people in a line with the movement of the resources and the goods, right? And also the expansion of empire. And so what is happening in the domestic around our conversations around public health and equity has everything to do with what's happening, right, in the international around public health, right? If we think about, this being a border, right, public health law, and, a lot of the coalition's work around bringing together these logics of homeland security with local policing is something that is very much on our mind. I want to just stop right there, because I think Jamie is going to take us into the next step from here, about what we were thinking could be the ways that we could all build with each other from this point on.
Thank you so much, Breann, Mienah, Bita. This was great. I feel like I learned so much too, and I really appreciate everything that you shared with us. But I also want to be sure if there's any questions out there, if anybody wanted to ask a question before we get into our call to action, because there's always got to be some action. No? Okay, well, even if you don't want to ask those questions, we want to offer a space where you can come and build more questions with us. So this is kind of us, this small crew of folks coming together and wanting to, formally be informally meeting. And we have been meeting right now about once a month. Sometimes we pick it up to 2 times a month, but we are kind of becoming more and more cohesive, working together as a unit. There's been 2 kind of goals the group has, in the sense of the spaces that we want to be and how we want to organize. And One of them, of course, is a front-facing campaign within the community, more localized, where we don't quite know what brick we want to throw or who we want to throw it at, but we know we need to identify where we're going to throw it. And one of the best ways we do that is by community-based research. So some of the ideas that we've been thinking about, of course, is, popular education, community-based research reports, focus groups, and some of the ideas just kind of really building off of what everyone was saying before, is that we started to do kind of thinking locally of what's going on in LA, and California actually has a fusion center that's involved in 4 different programs, public health programs. And so I just wanted to show as an example of things that we can be doing, but through the California Department of Public Health, the fusion centers have fusion center projects. Let's Get Healthy, violence prevention indication, community burden of disease, equity, recovery, and resilience. And so in some ways, and I just wanted to quickly just show this, we want to be able to start getting into the nitty-gritty of how do things like Title 42, that is kind of more of a national, obviously, law that was put into place. What does it look like locally on the ground? What does it look like in California? What does it look like in Los Angeles County? And how is data that's being collected, information that's being shared, public health data that's being collected, being weaponized, being utilized by the state to not provide the type of wellness and health that we need. So part of this call to action is saying these are some of the things that we want people to be involved in with us and having these conversations with us and doing this community-based research. So that's one angle that we wanted to go. And I know, Bita, you were going to talk about another angle and some of the work that we're actually currently doing right now to kind of throw a brick another way. It's like, I want to throw bricks, everyone.
Real quickly, Jamie, do you want me to put the email address if people want to join and do anything? It'll be the coalition's email address? Okay,
yes,
cool.
Please. Or please just drop your email too, and we can write it down if that's easier for you, because we can reach out to you.
And we really hope that you do, because, I think we talk about this with ourselves so much, we don't even know what the beginning, the middle, or the end is. So we would love to talk about it with other people. If anything, even if it's not interesting, just come join us, because we love each other, but we would love to love other people as well. I think the other key part here is thinking through this moment where we're like blending like 9/11, like domestic ideas of what is threat and threat management, with then public health saying it's had a racial awakening where it wants to study like the roots of white supremacy. And so, as I'm sure many of you all here know, with this whole like DEI, like white diversity, equity, and inclusion, like invention, right? That's really just a repackaging of cultural competency and a repackaging, right, of other things before it. The idea, the way to do kind of race right in public health is to, for example, and Mienah and I were having this conversation earlier today, is to study hate crimes, right? Like who commits hate crimes, who are the white supremacists, so on, so forth. So a public health model to like thinking through how to prevent, how to prevent crime, or how to deal with somebody who's committed a crime, is now also obviously being applied to issues of domestic terrorism. And, all that, like in quotes, right? So because of this, we're in this place where we're seeing once again, like public health logics being applied to something domestically, where there is a real gap in the knowledge about the connections between all this stuff and the field and its solutions and the traps. And as we're trying to like even just get the conversation around the way that public health surveillance, like what does that mean? How is it, how does it help us, but also how does it harm us, right? As we're even just trying to grow that, there's this huge ship that's been sailing, right? Around getting public health and disaster preparedness money to also move into homeland security, like, and domestic policing issues. And it's bringing many worlds together. And so the other ask is for folks to join, because we have some strong mobilizing that we have to do within public health to even try to make these connections. Because while folks, for example, will know that like at this moment, like, hey, it might be tricky for me to work with law enforcement and from public health because people are talking about policing, right? But still, wouldn't a public health model be so much better, right, than having cops on the street? As they're even navigating that, all of these strategies are being put into place on how to address, for example, the shootings, right? And these other things. And instead of ever getting, and so when we talk about like the public health that Mienah and the rest of us like we're drawn to, but we never get to do, we never get to look at the roots of these issues. Our tools and who we are and our workforce are always brought in to manage crisis after the fact. It's either crisis directly related to health, or it's a health crisis that's an artifact of another existing crisis that is being made, or in this case, just using us to manage, something else. And everybody here knows that crisis is both real because it's a product of, poverty, right? Segregation, lack of housing and all this stuff, but it's also manufactured. And so we sit at this place with wanting to do this work with the intent of like pulling resources, right, to movements or to like, or to community actions, to be supportive of it. But we're caught in a place where all of our money and all of our capacity is just being sucked and connected to all these kind of larger forces, with really no political education within the field about even what the field is. Nevertheless, what the coalition does. So, these are the challenges we find ourselves in.
So thank you everyone for hanging out with us. I think the coalition has a couple announcements to make, but I got emails. Thank you all for signing up, and we will be reaching out to you for our next meeting. And yeah, this was great. I learned so much, and I appreciate everybody for hanging in there with us.
Thank you all. This was great. And I don't know, Jamie, if you made a note that the Lyall, she would also want to be involved. They just posted their email address. So it's in the chat. Do you have it? Okay, cool. Yeah, so thank you again. This was we missed you guys, and I'm so glad that we just all circle back and with such intense and awesome conversation. Really, and really appreciate it, because these conversations can also get dense. But I mean, the way they were shared, they were just very community friendly, and I think this is where it's about building that. It's just decolonizing this knowledge. This is what the community needs on the ground to understand that what the heck are we dealing with. So really, really appreciate that. A lot of learning. Real quickly, I just want to also share that another fight that is brewing up is about the Care Court program, which is on a fast track and moving through California legislature, where they are criminalizing basically poverty and homelessness, and the goal is to establish a pretty extensive court system that would order people into mental health treatment and require them to take pretty powerful medications, antipsychotic medications and all, against their will. So they're calling it a voluntary program, but if you don't agree to that, then there's other steps as well. And, all leading up to even conservatorship. Like, somebody's going to take charge of your life. So in a sense, this fight is really brewing. There's a complete failure of any opposition on the California legislature at all. I mean, 0 to none, where Newsom has really come down very hard on the legislatures as well. So this is going through. So keep an eye out, because, from our vantage point, what Jamie was talking about, fusion centers and the stalker state and information sharing, that's going to go in overdrive. So that's where the public health expertise is needed, and really kind of building this and decolonizing this knowledge and building that power on the ground as well. So with that, just fourth Tuesday of the month is coming up. Next Tuesday, we have our data-driven policing, meeting. So we'll be going back to looking at the various ways that are focusing on the LAPD as how they're coming at us, how they're tracking us, how they're monitoring us, very much similar to what we are talking about. And of course, the expansion of other tools as well that are very much in the works, from expanded drone usage to what they call shadow teams or infiltrators, which are all this being codified and normalized in our daily lives as well. So with that, I don't know, I'm just going to see if any one of our team members, Shakir, Matios, Nina, if you have any other thoughts for closing or any comments, any message to the folks, anything coming up?
No, just to the Public Health Working Group for sharing with us, and yeah, and for teaching us so much.
Matios, Nina, anything?
Yeah, thanks so much, everybody. If folks are available, we'll be at the Mocha Geffen Contemporary this Saturday from 2 p.m. to 10 p.m. for a music theory festival. Should be a lot of fun.
Awesome. Nina, anything?
Yeah, and folks are interested in any of the dates that we mentioned here, or just to see if you'd want to plug into any of our outreach efforts as well. We also have a calendar that folks can access online. If you visit stoplapdspine.com, you will also be able to see in the meetings tab a list of the calendars with all the different events as well.
That was .org, just a slight correction there, stoplapdspine.org. /calendar. Achella, Akhil, anything from you all?
Nope, I am not planning anything.
All right, cool.
Yeah.
All right, Akhil?
Just lots of gratitude for the public health people for such a powerful and thorough presentation. Thank you.
Great. Thank you all. So first Tuesday is our conversations around gender and sexuality, how the police state intersects with that. Second Tuesday is the fight against war on youth, and how youth are being targeted under the National Security Police State. Third Tuesday is a general meeting where we bring in folks and our comrades and our partners to have these conversations. And fourth Tuesday is data-driven policing, along with a whole lot of different working groups. So join the fight. We will end this drama that continues in our life, and we will abolish this fucked up system. So thank you, everybody. Have a good night. Appreciate it. And the tape of this YouTube will be on our YouTube account by Saturday. So thank you.